All right, let's just jump right in. Today's explainer is all about Chapter 46, our clinical study guide on periodontal splinting. If you've ever looked at a case of severe tooth mobility and thought, how on earth do I stabilize this without making it worse? Well, you are in the exact right place. We're going to completely break down the complex what, why, and how of locking down mobile teeth. We're unpacking the clinical evidence, the biological rationale, and the exact workflows you absolutely need to know. Here's our quick roadmap for today. We'll hit the fundamentals of splinting, the physiological rationale, and how to classify splint types. Then we'll get into the actual clinical principles and workflow, weigh the indications and trade-offs, and wrap up with key evidence you students need for exams. So, Section 1, the fundamentals of splinting. Let's start our chalk talk with the core diagnostic problem. When a patient walks in with a tooth so mobile it messes with their chewing or comfort, how do we actually fix that? Well, to answer that, we have to look at the literal definition of the procedure. Dental splinting is the joining of two or more teeth into a rigid unit, using fixed or removable devices to maintain or stabilize mobile teeth in their functional position. Basically, a splint is just an appliance used to immobilize injured or diseased parts. Think of it exactly like a cast on a broken arm. It locks things down so healing can happen, and it gives the patient some much-needed comfort. Now, there's a pretty stark contrast between the two main schools of thought in periodontics when it comes to this. On one hand, the benefits are super clear. Splinting stops mobility during chewing, and, it's just a fact that non-mobile teeth heal way faster than mobile ones. But on the flip side, there are real serious risks. A splint can easily become a massive plaque trap. Plus, by totally eliminating the natural functional movement of the tooth within its socket, you run the biological risk of ankylosis. That's where the tooth root literally fuses straight to the surrounding bone. So it's a really delicate balancing act. Moving right along to Section 2, the physiological rationale. Let's look at the biological mechanics happening beneath the surface before we even touch the clinical hardware. Okay, these are our primary physiological objectives. First and foremost, we are desperately trying to give the periodontium a rest. I mean, human jaws can generate up to 200 pounds of force when chewing. That is huge. To handle that crazy load, we use the splint to redirect forces in a more axial direction over all the included teeth. We're redistributing that force so no single tooth takes a hit that exceeds what the tissue can actually adapt to. On top of that, by restoring proximal contacts, we preserve the whole arch integrity. This brings back functional stability, increases chewing efficiency, and honestly, we cannot ignore the psychological relief it gives a patient who is just terrified of losing a loose tooth. And this brilliantly illustrates the ultimate goal here. Splinting isn't just some temporary band-aid. By redirecting and redistributing those occlusal forces axially, and by closing those gaps to restore proximal contacts, splinting actively stops the cycle of destruction. It prevents further long-term periodontal breakdown by managing forces and stopping food from constantly jamming into the periodontium. It is a real game changer. All right, Section 3, classifying splint types. With the biological rationale firmly established, let's open up our clinical toolkit. When classifying your options, you really want to commit this breakdown to memory. First, we classify by the period of stabilization. Are you placing a temporary splint for less than 6 months, maybe a provisional one for a few months to years, or a permanent splint to be used indefinitely? Next, we look at the material type, like a bonded composite resin button, braided wire, or A-splints. Your choice here totally dictates the rigidity. Finally, we classify by location. Are you working intracoronally, utilizing slots inside the tooth with composite and wire? Or are you going extracoronal, using tooth-bonded plastics or night guards for external stabilization? Ultimately, your specific clinical application is going to dictate the exact combination you choose. That brings us to Section 4, clinical principles and workflow. We know our tools, but how do we actually apply these principles functionally in the clinic? Listen up, because these 4 points are your absolute golden rules of splinting. First, the healthy teeth ratio. You need enough healthy root surface area to act as a solid anchor. Specifically, you need double the root surface area of the mobile teeth you're trying to stabilize. Second, you absolutely must splint around the arch. If you only splint one small straight segment, the inward forces from the cheeks and lips, combined with the outward pushing from the tongue, will literally cause that entire splinted segment to collapse or tilt. By including firm teeth from an adjacent sextant, you neutralize those muscular forces. Third, always perform a coronoplasty, which is just reshaping the biting surfaces to relieve any traumatic occlusion before you do anything else. And finally, please, design the splint so the patient can actually keep it clean, Okay, imagine you're in the clinic right now. Here is your step-by-step workflow for a super common procedure, the temporary anterior splint. Step 1. You use a direct bonding system with standard acid etch techniques on your target teeth. Step 2. Apply a light-cured resin. Step 3. Place an intracoronal stainless steel wire right into the slots you've prepared, locking the teeth together, and then cure the resin. Boom! It's a simple, economical, and highly stable design when executed correctly. Section 5. Indications and trade-offs. This brings us to a critical juncture. When should we actually use this workflow? And maybe more importantly, when should we avoid it entirely? Let's look at the main indications. Splinting is incredibly advantageous when you have moderate to advanced mobility that just hasn't responded to occlusal adjustment or standard periotherapy, and it's actively interfering with the patient's chewing. It's also a fantastic tool to stabilize teeth during active surgical or regenerative procedures. And of course, it is absolutely vital after acute dental trauma, like a subluxation or avulsion. You use it to lock the tooth in place while the periodontal ligament heals, or to prevent unopposed teeth from drifting and extruding. However, it is definitely not a magic cure. You should never, ever splint if the patient has poor oral hygiene or if you haven't adjusted existing primary occlusal trauma. Why? Because of what we call the lever effect. A rigid splint acts exactly like a lever. If just one single tooth in that splint is in traumatic occlusion, it transfers those destructive forces to all the healthy teeth connected to it. You end up injuring the entire unit. You also trade stability for an increased risk of caries and plaque accumulation. And here is the harsh clinical reality we have to accept. Studies show that splinting does not actually reduce the underlying tooth mobility once the splint is eventually removed. It really only provides stability while it's physically attached. Finally, Section 6, Key Evidence for Students. Let's distill the core literature takeaways so you undergraduate dental students are fully prepped for your exams and clinical boards. This quote perfectly synthesizes the duality of the procedure. Yes, splinting decreases mobility and thereby can improve the health of the tooth by allowing the periodontium to rest. However, if used incorrectly, like, say, failing to secure enough healthy abutment teeth, or if it's not managed properly by the patient with meticulous oral hygiene, it will fail to achieve the desired results. In fact, it could even accelerate bone loss. Case selection and execution are absolutely paramount. So I'll leave you with this provocative clinical scenario to ponder before your next clinic session. If a patient presents with a moderately mobile tooth but has poor oral hygiene and unadjusted primary occlusal trauma, would you splint? Think critically about the biological trade-offs, the lever effect, and the strict requirements for plaque control we just explored. Understanding when not to splint is just as crucial as knowing how to splint. Keep that in mind and you'll be well on your way to mastering periodontal stabilization.